All right, blood products. We'll see if we get lucky with blood. So again, there's going to be, we're just separating out the blood and we are giving it to the patients. And you have to identify the right patient, right blood product for the right patient, right? So it's going to be based on labs. It's going to be based on if they're like bleeding out. All right, they might have obvious signs of bleeding, right? So we talked about obvious signs of bleeding, like life-threatening bleeding. And what's an example of life-threatening bleeding? A GI bleed, right? A GI bleed or a head bleed. Those are usually going to be it, right? Obviously, they come in a trauma, right? An accident of some sort. That's going to be an indication for bleeding, usually, or for blood products at least. Okay, so blood products we're going to separate out into the PRBCs itself, right? That's probably your most common one. That's the one you can get checked off on today. And you have to know the procedure, and the procedure is the same for PRBCs that it is for platelets and FFP and other products, right? Because everything else is not PRBC, right? And we'll talk about a few of those. Next semester, we'll talk about like DIC, which is a disease process where you need to give platelets, you need to give cryoprecipitate, you need to give all kinds of other products, right? So blood product types. Okay, so today you do have to know this. You have to know this for your quiz as well, right? And please don't memorize that. That's not going. You're not going to say check, check, x, 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 o, o, x, x, check, check, check. That's not going to get you anywhere. You have to learn the reason why, and that's why I am here to give you the reason why, so you can get to the right answer every single time. So you can fill out the table on your own. So in your practice time before your quiz, you should go up to the whiteboard and you should just, bam, I'm going to fill this out, right? And you're just going to work it through, right? And then it'll become second nature. It's like, oh yeah, B products, they can't get A products, okay? And sometimes there's some rules like that, like you don't give positive to negative, so that's going to be a quick rule, right? And then you're not going to give opposites, like you're not give A to B or B to A, and and we'll give you the reason why, but at the end, it's going to make a little more sense, okay? And then for your checkoff today, for quiz, that's this guy. For your checkoff today, you'll be going over transfusion reactions, right? So those are indications, sorry. This is your transfusion reactions. What can, and the reason, one of the ways to set up this correctly so you don't get the blood cells popping on the way in, right? You don't want them just pop, 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 pop. It's not gonna be effective, right? You want whole RBCs. So we want to make sure they're not hemolyzing, right? They can hemolyze because we didn't choose the right IV fluids, but they can also hemolyze because we didn't choose the right blood product, which goes back to the table there, right? You gotta make sure you're using the right blood product, otherwise the patient's blood will attack that blood, okay? And we have what are called antibodies, and we have antigens, right? So which ones are floating in the bloodstream? Well, technically they both are, but which one is found on the RBC, which one's found in the bloodstream? So here's an RBC right here, right? What is, and there's little things on it, and what are those things called? Antigens or antibodies? Antigens, right? So gens are generated on things, right? So they are found on cells, right? They're found on every living thing in the universe, right? And so a bacteria has antigens, a virus has antigens, everything has antigens. Okay, everything creates some kind of license plate or social security number for themselves, right? And then we form antibodies against those. All living creatures usually form antibodies against antigens, right? Hopefully you don't form it against ourselves, right? Like in myasthenia gravis, we formed it against our own cells, right? Or we formed it against things. Like myasthenia gravis, technically you formed it against the recent infection, right? That bacteria came in, you formed antibodies against it, and that bacteria looks so close to an acetylcholine membrane, right? Acetylcholine receptor. So then it attacks it, right? Same thing with like myasthenia gravis. You're attacking your own cells because you formed antibodies against a foreign invader, right? And then just so happens that the antibody looks the same, or that foreign invader looks the same as our Schwann cells, okay? So that's the idea, is they have antibodies and antigens, right? And when it comes to blood, you form antibodies against what you don't have, right? So if you have a triangle antigen, you're gonna form, and let's say there's triangle and circle antigens out there, and you only have triangles, you're gonna form antibodies against circles, right? So you're gonna have anti-circle antibodies. So we'll talk about that, right? There's A antigens, B antigens, and there's something called a D antigen, but they renamed it the RH factor, okay? So we'll look at those. And the RH factor is your negative or positive. So it's either not there, negative, or positive. It is there, okay? So we'll talk about some of the different risk factors there, infection, etc. And then like when do you transfuse? We'll talk about some of the indications for transfusion. Obviously, if your PRBCs are low, you're going to give PRBCs. If your platelets are low, you're going to give platelets, right? If you're bleeding, that means your coag factors are low. Where are coag factors found? They're made in the liver, but where do they go? Where does the liver dump them to? Dump them into? The blood, right? So the blood has coag factor just circulating throughout, right? The blood's ready to go in case you have an atheroma pop, right? So bam, there I am, I'm here, right? And it's going to form a clot, right? Or if there's some kind of trauma, you get poked or stabbed, right? It's gonna then clot right there. The blood needs to be ready to go to coagulate, right? So the coag factors are there. So if you have an absence of coag factors because maybe you used too much in a trauma, you used them all up, then we have to replace them, right? Or you have a liver that's not working, not producing the coag factors, then we have to replace them, right? Or you took anticoagulants that permanently inhibit them, like warfarin. It does not recycle your coag factors. Your liver works super hard to make coag factors, and then you give a vitamin K antagonist, such as warfarin, which inhibits the recycling of it. So you're not recycling what you could recycle. Just like us in the skills lab, we recycle NS bags, right? It's like if we didn't make, just use the NS bag and throw it in the trash every single time, that's going to, eventually you might run out. You're at risk for running out or bleeding, which is what happens when you run out, right? So then we'll talk about FFPs a little bit, right? FFPs is another blood product. We got platelets, it's another blood product. There's cryo. We'll talk, that's another derivative we'll talk about a little bit more next semester, but that's something you can get from blood. All right, so what is in blood? So there's plasma and cells. All right, the cells are what? What cells are found in blood? Red blood cells, that's one of the important ones. What else? White blood cells, what else? Platelets, that's it, right? You don't transfuse white blood cells, that's not a thing, all right? We can stimulate them to grow. We have white blood cell stimulating factors, or like Neutrogen or Neupogen is going to stimulate white blood cells to stimulate the bone marrow to make white blood cells, right? But we don't transfuse white blood cells, but we do transfuse platelets and RBCs when they're low, okay? And then you have plasma. So in the plasma itself, you have all kinds of fun stuff, right? You got water, proteins, nutrients, hormones, other things. And then we have the RBCs here, right? So we can split, we take someone's blood and we centrifuge it, we spin it around. You probably did this in a physiology lab, right? Where you looked at your RBCs and the percentage of RBCs to plasma, right? That is your hematocrit, right? That is how much RBCs percentage of your blood volume, right? So if you're dehydrated, right? You don't have enough water. Where's water at? It's right here, right? Your hematocrit's going to rise, right? You're going to have more RBCs to plasma because you're lacking water, and water is what makes up plasma, okay? And then you have the buffy coat. So the buffy coat is just separate. When you separate it out, there's a nice little milky fat layer right there in the middle. Some of us have more milky fat than others, okay? There's a little milky fat layer there in the middle, and that little layer has all the things we didn't talk about yet, right? That would be your white blood cells and your platelets. Okay, but that relationship, that ratio of those two is going to be, you can tell if someone's dehydrated, for instance, their hematocrit would be elevated, right? And by the same token, if someone's bleeding and all the RBCs are coming out, the RBCs are going to be low, right? So therefore, that's going to make by percentage go lower. When we talk about hematocrit, we're talking about percentage of RBCs to plasma, right? What's the percentage? What's my test score for RBCs? Okay, so if I'm bleeding out, my hematocrit would also be low. Okay. So hematocrit or hemoglobin are usually H and H. Those are the two that we usually interchange. And we look at to say, hey, if their hematocrit's low, we might have to give them packed RBCs. We have to give them RBCs. But hematocrit, usually we don't follow that much. That's usually the only reason is because the research out there. The research usually always targets hemoglobin instead of hematocrit. And where's hemoglobin found? In RBCs, right? The hemoglobin is found in RBCs. So if you have less hemoglobin, that means you have less RBCs, right? The hemoglobin is not just floating in the bloodstream, right? Like antibodies are. And what else is a big protein that floats in the bloodstream that holds on to water? Starts with an A. Albumin, right? So albumin is one of the proteins here, right? So we got proteins, right? Such as albumin. right? And then also you have antibodies floating in there that are attacking, we usually have a certain amount of antibodies, right? You get your titers done before you got into school, and they're looking to see, do you have titers against hepatitis B, for instance, right? Do you have titers against certain like measles, mumps, and rubella, right? So they're looking to see, do you have those proteins just floating around at all times, right? And we'll talk more about antibodies and IgG and IgM and all those other fun stuff in Med-Surg too, with hematology and such. But this is where they are. They're floating in there, right? So what else? So we got the RBCs, all right? So if your RBCs are low, your hemoglobin's going to be low because the hemoglobin is found in the RBCs, right? You could even look at, we do have an RBC count, right? RBC count is the amount of RBCs that we see in a cubic millimeter. But it's one of the three. Are we going to do hemoglobin, hematocrit, or RBCs? Because when RBCs are low, all three of those are low, right? So when the hematocrit is low, the RBCs are low. When the RBCs are low, the hemoglobin's low. So we got to choose one. And usually the hospital setting, we're choosing hemoglobin. Hemoglobin is the one that we're looking at to say that's, we got to pick one, because you're not going to say, okay, the hemoglobin's low and the RBCs are low and the hematocrit's low and they're bleeding, right? So it's like you got to pick one, okay? So what's an approximate hemoglobin? About 15, all right? It varies for women and men because women bleed every month, right? When they're before age 45 or so. So that's going to be a reason why their hemoglobin is going to be lower than men at baseline, okay? So it's, yes, men have more muscle mass, but that's not the reason for the hemoglobin change. Okay, so it is a 1 to 3 relationship between hemoglobin and hematocrit. So if my hemoglobin's 7, what's my hematocrit? 21, right? Hematocrit's the percentage of it, right? The percentage of RBCs to plasma. So if the relationship of that, if I have 7 hemoglobin, my hematocrit is 21, right? So it's a 1 to 3 relationship. So if my hemoglobin is 15, normal, what's my hematocrit? 45. 15 times 3 is 45, right? So again, my hemoglobin is 10. What's my hematocrit? 30, right? So that's the idea, right? You can have too high of a hematocrit. That's called too many cells, right? Or polycythemia, right? You can have too little cells, and that's not, what's it called? What am I trying to look at? There's a hyponemia, right? It's not hyponemia, unfortunately. It's anemia. Anemia technically means without cells, but it's you're either anemic or polycythemic, right? Those are the two extremes. Or you are in the middle, which is, I guess, eunemic, right? Eu meaning normal. But you have either a low or a high hemoglobin, right? And if you want to know what the hematocrit is, it's going to be a 1 to 3 relationship. Okay, so what else? We can talk about buffy coat, has your white blood cells and platelets in it. Your plasma has everything else, your coag factors, your albumin, all the other things. Okay, and we can derive those things from the plasma. We can take that plasma and we can play with it and we can get things out of it, right? And then we talk about 3 to 1 relationship, and then increased hematocrit. That's called polycythemia, right? So when we talk about respiratory, there's with COPD, there's 2 varieties of COPD. One has a hypoxic variety, one has a hypercapnic variety. What does hypercapnia mean? It's no cap. What does it mean? CO2, right? So hyper CO2 anemia or something, right? It has too much CO2 is hypercapnia. Too little O2 is hypoxia, right? So we have too little O2. Well, your body's gonna say, well, shoot, why there's too little O2? I know how to fix that. The tissues are starving of oxygen. Let's just make more RBCs, right? So we make more RBCs because of low oxygen states. So respiratory diseases like chronic respiratory disease, where we have chronic hypoxia, that's going to make us spew out more RBCs, and therefore our hemoglobin hematocrit go up or down. If I'm making more RBCs, they're going to go up, right? So that'd be in respiratory disease, right? And then dehydration. So dehydration, you are losing water, right? So the hematocrit is going to go down or up if you're losing water. No. It's going to you're going to have more RBCs to where the water was, which is plasma, right? So that plasma is going to shrink, all right? So you can imagine like this top one right here, right? So we got someone that has you're either losing water, right? This one typically is looking at polycythemia, but it kind of looks the same. You're losing that water, right? The reason why your hematocrit's elevated is because more RBCs gained, you got gained more RBCs, or you lost more water, right? Your percentage is different, okay? And then diarrhea. Why does diarrhea cause dehydration? Because you're losing water, right? So you're losing water and stool. So the treatment for that is give fluids. So 45 is our normal. So if you're getting like 50 or so, that's a clue that you are dehydrated, all right? And then decreased hematocrit. That's what we see a lot, right? We see a lot of decreased hematocrits, and it's because you can't make hemoglobin, right? So why can't you make hemoglobin? Well, maybe the RBCs don't respond to it because you don't have the building blocks to make RBCs, right? What are the building blocks of RBCs? Well, hemoglobin, right? And to make hemoglobin, you need iron, right? So iron is a part of hemoglobin. And then to form RBCs, you need folic acid and B12, all these things, right? And we'll talk more about anemias in Med-Surg too, like what happens with my B12 deficiency. Well, you're gonna get anemia, right? That's the first step. And then we'll talk about the symptoms and treatment and such in Med-Surg too. But so iron, folate, and B12 deficiency, those are the three major building blocks of hemoglobin, but also of making RBCs. And then kidney disease, right? When you have kidney disease, you have decreased EPO. What is EPO? Erythropoietin, right? And it poietes erythros, right? What does poiete mean? It means not eat. It means make, right? So poietin is a stimulation of, right? A stimulation of erythros, right? So we're gonna have erythropoiesis because of EPO, right? So it's gonna make more RBCs, and who's in charge of that? I don't know how the kidneys got this job, because that has nothing else to do with them, right? They don't care about being oxygenated or things like that. So I'm not sure why they got that job. It should have just been given to liver. Liver does everything else. The liver makes thrombopoietin, and what does that mean? The creation of thrombi, right? And to make thrombi, you have to have, that's platelets, right? So the platelet stimulation, right? When your platelets are low, well, the liver's like, hey, say no more. Here's some thrombopoietin, right? And it's going to tell you, and that thrombopoietin gets made, it goes to our bone marrow to make more platelets, right? And when your oxygen is low or your RBCs are low, somehow the kidneys are like, oh, I'll take over, I'll do this job, right? So people with kidney failure are always anemic, right? And we have to fix that. Well, you're going to see in clinic, they're getting iron, folic acid, B12. They usually get that in the form of like a NephroCap, a multivitamin, right? And they usually get a erythropoietin shot every week to supplement their erythropoietin that they're missing. Okay, so how else can you lose RBCs and get how else can you get a low hematocrit? Is losing the RBCs themselves, right? Losing RBCs, you're going to be left with what? More plasma, all right? So that means the hematocrit's going to be low or high. It's going to be low, all right? So we have trauma, GI bleed, menses. All these things are going to be a loss of RBCs, and therefore the hematocrit's going to be low. And then fluid. So if you give fluid to someone, right, it's like it's called a pseudo-anemia. So we are falsely making the hematocrit low, right, because we are adding more fluid, right? All we did is falsely put fluid into the pot, right? So you're like making soup, right? You make it more dilute, right? The percentage of soup to broth is going to be, there's going to be a lot more broth than soup, all right? So it's like this soup's hematocrit is very low. What's going on, right? So usually when you go to the ER, an ER visit, you're going to get 3 liters of fluid. It's like a welcome package. Like, hey, welcome to the ER. Here's 3 liters of saline, right? And that's going to make you dilute, right? When someone's super dehydrated, that makes sense, right? But sometimes when they come with like sepsis, or they come with other like low blood pressure, they're going to give them 3 liters of saline, and it's going to dilute their hematocrit. Okay, so that's something also to consider. Usually, like day 0, when they go to the ER, the H&H might, it might look low. Or sorry, my H&H might look normal, or it might be super high, or it varies. But the next day, if they get 3 liters of saline, you're going to see, whoa, shoot, look at that H&H went really, really low because they gave so much fluid. Okay, And there could be bleeding happening because it's a little bit difficult. It's like, well, are they bleeding or not? Because if my hematocrit's low, they could be bleeding, right? But you have to consider, like, my hematocrit went from like 45 normal to 40. It's like, well, are they bleeding? And they look at the patient. They're not bleeding, right? They don't look pale and anemic. It's because the ER gave them 3 liters of fluid, right? That's what diluted them out. And then usually that's why we trend it every day to make sure, okay, that's ER's fault for day 0 to day 1, right? But what about day 1 to day 2? If it's still falling, there could be an occult bleed, right? What does occult bleed mean? It means when you bleed inside of a cult? No. It means when what? Occult means the mysterious and the magical, right? So if someone's an occult wizard, they are dealing with the mysterious stuff, right? So it's a mysterious bleed or a bleed you can't see. Okay, so it could be bleed in the head, it could be bleed in the GI tract that hasn't come out yet, it could be a bleed in the belly, it could bleed in the bladder, all these things. Okay, so that's the idea behind H and H. Okay, so there are differences, and when you get to OB, you might have some differences there. When you get to peds, you might have a few differences, but H and H is not going to change, right? And the one we usually look at the most is hemoglobin. Hemoglobin is going to be our kind of our line in the sand for whether we need to transfuse RBCs or not. Okay, and the relationship again, hemoglobin times 3, right? So if you can't figure out was it the hematocrit or the hemoglobin multiplied by 3, well, if you multiply your hematocrit by 3 at 45 times 2, you're getting like hundreds, right? That's not going to be correct. Okay, so it's the low number you multiply by 3. All right, so blood transfusions and alternatives. So you can transfuse blood to a person. So where does the blood come from? You can transfuse it. You can transfuse their own blood, right? So you take the blood out and you give it back. It's like, well, I'm already anemic. What are you doing? Why are you taking my blood away, right? That's usually with someone going to surgery, right? Someone going to surgery and they're losing all this blood. We'll spin it around and we'll filter it out. We'll make sure there's no bacteria in it. We'll go do all kinds of things, and then it will then go back into their veins, right? So in the bottom left there, that's an example of an autologous transfusion. All the blood that comes out during surgery via all the suction devices, via all the things they're doing, and they suck up from the field, and there might be bleeding that happens. All that blood gets into a little blood transfuser, a cell saver, I should say, and that will save the cells, and it will transfuse it, because if you let the blood just sit, what's going to happen? Going to clot, right? So we got to keep blood in motion, right? Like AFib or big CHF with dilation, it's going to clot, right? So we have to prevent it from clotting, right? So we can then, we're transfusing it, and then we wash it as well. It goes through a whole process, and then it gets put back in the patient, right? That is not what you're learning today. You're not going to be learning how to do a autologous blood transfusion, right? What we do is homologous, right? So that's where you get it from another homo, right? What's another homo? A human, right? So we get it from another human, from an anonymous donor. I mean, it doesn't have to be anonymous. You can find a friend who has the same blood type as you. It's like, hey, you got me when I go in the hospital? Yeah, I got you. Then say no more, okay? So that's from an anonymous donor, where we take the blood out of them and we put it into a little blood pouch, right? And we save it for later to give to someone that needs it, or to a vampire who pays enough money, right? One of the two. So that's going to be your options with a blood transfusion. Okay, so that blood is going to sit there. So how does you prevent that blood from clotting? You just got to get someone. You got to pay someone $17 an hour to shake it. I'm a pro blood shaker. That's my job. No, it goes to a fridge somewhere. It gets stored at a cold temperature. And how do you prevent it from clotting? Calcium, right? It has to deal with calcium. So you don't give calcium because calcium is part of the clotting cascade, right? If you give calcium to some blood, it's going to, oh, I got more tools to make clots, right? So we give something that stops calcium. We give a calcium antagonist. We give something that's a preservative that's going to block the calcium, right? So that preservative is put in the blood when they collect it, and it's going to prevent this from clotting, right? So we're going to inhibit calcium. We have different varieties of preservatives. So there's different ones on the market, but EDTA is a common one. It's going to stop the calcium from it's going to stop the calcium, or it's going to inhibit the calcium. It's going to bind to the calcium. It's going to chelate the calcium and prevent it from starting a clot, right? Because we don't want to give a clot to the patient. We want to give nice, smooth blood, right? But how do you, when you give this, how do I take that preservative out? I give this blood product. Filter? No, you can't filter out EDTA, right? So it's like you're getting EDTA. Sorry, it's going in, right? You're giving them the preservative and the blood product when you give a homologous blood transfusion. So that's getting to the patient, right? So that by that token, the patient's at risk for what? Dyselectrolytemia or abnormal electrolyte problem. Hypocalcemia for that exact reason, right? So if you can't remember, is it hypercalcemia? All you have to do out of this lecture is know which one it is, right? So when you know the why, you can then get to the right answers. Like, oh, I'm giving a preservative. That preservative blocks calcium because calcium is part of the CoAG cascade. That's gonna, well, obviously, if I give that to them, it's gonna block their calcium too. You can't just turn it off and say, don't, you know, you can't whisper to it, hey, I know you're doing a good job right now, keeping this blood nice and unclotted, but if you could just do me a favor, not clot the patients, that'd be great. That's not going to happen, right? It's going to give it to the patient. It's going to bind the patient's calcium also. Okay. Anyways, there's alternatives to blood transfusions, right? So there's Jehovah's Witnesses that classically don't receive blood products. So they have an issue with blood leaving their body and going back to their body. And once it leaves your body, it's done. So if it does leave the body, sometimes it depends with the Jehovah's Witness whether they want that blood to come back, like with their own blood, right? Or if it's a foreign blood, they're definitely against foreign blood. That's like 100%. That can't happen. But sometimes they leave it up to the Jehovah's Witness itself. They say, okay, it's okay. Let me know, or it's up to you. It's a personal decision whether you want that blood, like with an autologous transfusion, to happen. But definitely it's against your religion to do the homologous blood transfusions. And sometimes they, even like dialysis, you take the blood out, right? And then it gets filtered and it comes back. Sometimes that's against their religion. It's their personal choice, but that is their prerogative. And then what does it say as well? So where's I going with that? So plasmapheresis would be the kind of similar thing, right? Plasmapheresis, all the blood is leaving your body and you're replacing, and it's going to get returned, but you take all the plasma out and replace it with what? In plasmapheresis, you replace it with albumin, right? So albumin is replaced. Albumin is going to be the replacement factor because we take all the antibodies that were attacking us in myasthenia and Guillain-Barré and other autoimmune conditions, and we do plasmapheresis to take out the plasma, right? And replace it with something. You can't replace it with nothing, otherwise what's going to happen to your hematocrit? It's going to go up or down. It's going to go up, right? The percentage of RBCs to plasma, if I take all the plasma out, RBCs are going to go all the way up, right? So that's the Bible commands abstaining from blood. So does that mean like rare meat, or does that mean blood entering my body? So that's why they're saying, well, if it leaves my body, I don't want it to come back to my body. But definitely, I'm not against someone else's blood just being given to me, right? I'm not gonna volunteer for that. Okay, so cannot donate blood, store blood, or allow it to dwell outside their body. Okay, and a decision of them really for the alternatives to blood. So they're definitely not gonna. They're gonna abstain from blood itself, right? So RBCs on the not acceptable side, definitely blood is not going to be given, all right? So PRBCs are not given, all right? We do give whole blood in certain situations, usually in traumas, we'll give whole blood, but we don't give white cells, but it's on the list, all right? So they didn't get a medical consult for this. So the white cells are not transfused, right? And plasma they're not going to accept FFP or fresh frozen plasma, and they're not going to accept platelets, right? That's not going to be on the list. And then personal decision is here. So do we decide, do we want dialysis? Do we want other stimulating factors like erythropoietin, right? We can give you erythropoietin to stimulate your production of RBCs. We could give you other derivatives of blood products. Okay, so options that are a little more realistic, like albumin, is going to be a good thing to support their blood pressure a little bit, but to expand their volume. But we'll talk more about albumin. That's not going to carry oxygen. Our primary job when RBCs are low is to find a substitute to carry oxygen. There's really no valid substitute you can give besides blood. All right, so we have growth factors that will, diet is something we can encourage if someone makes it out of the hospital with anemia. They say, well, you got to increase your diet, especially iron, folate, and B12, because those are the building blocks for RBCs. And then this is up to them with cell savers if they're gonna choose that or not. We have DDAVP. Remember, it's under witness protection. DDAVP is also known as ADH and vasopressin and D-arginine. You know, it has all kinds of different names, but DDAVP also has another job out there. It actually stimulates RBCs and platelets to work, right? I shouldn't say platelets as much as RBCs as much. It really stimulates your platelets to function well, right? It's like a little cheerleader, okay? And then we have blood substitutes. We have different, there's other substitutes out there, but they usually have allergic reactions that aren't that great, okay? So again, not acceptable versus acceptable alternatives. And they have a whole list of interesting things there, and a lot of these things don't actually fix the problem. So there's a huge list there, but this is, you know, some people really follow and make sure that they are 100% on this, following this list. But again, every Jehovah's Witness, you can't say, oh, you're not going to take blood, are you? You have to make sure you identify what they are and are not going to take, because a lot of it is left up to personal decision, is what they will, you know, will consider or not consider. Okay, so blood product overviews. What are the different types? All right, so we had talked about PRBCs. Those are packed RBCs. The RBCs that are packed in there. Okay, that's the cell component. We're taking that out, and we're just taking away the plasma, right? So we're just giving the RBCs itself. There are a little mixture of other things in there, but it's a negligible amount. Okay, and this is for an active hemorrhage. It's for a low hemoglobin. And whole blood is rarely used. It's getting more traction for trauma centers. All right, so usually trauma. And then low hemoglobin, we'll talk about the target, but usually hemoglobin gets less than 7. That's where they'll say, you know what, it's time to give you blood. Your hemoglobin is now less than 7. The other thing is also, or you're bleeding, right? Oftentimes the lab will say, I'm not going to give you blood because your hemoglobin is 10. It's like, well, have you been to the room? It looks like a massacre, right? I need blood. They are losing blood. 100%, I guarantee the blood counts are low, right? Because it's going to take a second for that to keep, because it was 15 and now it's 10, that's a problem, okay? Because whenever you give a blood product to a patient, when you give like a PRBC, I should say, it's going to raise your hemoglobin by about 1 to 3 points, okay? Usually about 1.5 points. Right, so that's what you should expect if someone's not bleeding. Okay, so FFP, derivatives of FFP. So that plasma there, this is going to have all kinds of fun stuff in it, right? So all this stuff here is in plasma, right? So you mentioned PCC before, right? PCC was for our anticoagulant overdoses, when our anticoagulants got haywire, and they're soaking up all the different clotting factors, right? They're inhibiting all these clotting factors. Well, shoot, let's just give them the clotting factors back, right? So there's all kinds of fancy factories that take the plasma from humans, and they will filter it out and get the things they need, right? And then they sell it as a blood product, right? So PCC, or prothrombin complex concentrate, it has all those factors there, and that are going to be there for an anticoagulant reversal, right? And for all the work they do, they charge about, I think it's like $1,000 a unit or something. It's like something ridiculous. Like, I think it's like $140 a unit, but then it's like the patient needs like 80 units to turn them around. So it's a ridiculous amount. It's usually about 9 to 12K on average per dose. Okay, and then cryo. So cryoprecipitate is kind of like PCC, but it's just a certain variety of clotting factors specifically for DIC. And DIC, you're using all of your clot building blocks, such as clotting factors and fibrin, right? When the coag cascade finishes, you have fibrin, and then you have platelets that will bind to it, right? So to make fibrin, you need fibrinogen. So what does cryo provide? Provides fibrinogen, right? That's kind of the difference between it and PCC. It's going to provide the building blocks for a clot, okay? Because in a anticoagulant overdose, it's not usually you're short on fibrinogen. You're usually short on the clotting factors, okay? And there's pure coag factor derivatives. You could say, just give me factor 8, please. I just want factor 7, right? And it's like, why would you just want a specific factor? Why not just get the whole deal? Just go to PCC, or the whole way. Well, patients have genetic diseases where they don't make factor 8, right? Those are hemophilias, right? So hemophilias, there's factor VIII deficiency, there's factor VII deficiency. So we give just specifically what they need, right? And that's the cure for that disease process. And then albumin. So albumin is a protein that has 70 times the power of sodium, right? Wherever you give albumin, water is going to follow it, right? It's going to follow it 70 times more than sodium would, okay? And it's for volume expansion. They used to give it for blood pressure, but it doesn't. Yes, it will raise your blood pressure, but it costs about $100 to $300 a bottle. And a normal saline bag does the same thing. There's no difference in efficacy. So, and normal saline costs $1.25, right? So it's like, which way do you choose, $1.25 or $300? So they're going to choose the normal saline. So we don't give it for BP. And then so we got the plasma, right? We got the RBCs. And the last thing is platelets, all right? So you have an active bleed. You can't stop. You can't at the cut say, don't do bleed platelets, please. Just the RBCs. I'll give you a deal, right? You can't do that. RBCs are coming out. Platelets are coming out. All the things, plasma's coming out. All that stuff's coming out, right? So if someone's actively bleeding, we'll give them platelet transfusions as well, right? You give them an RBC transfusion, and you give them a plasma transfusion, and you give them a platelet transfusion when someone's actively bleeding. Okay, sometimes people just have a low platelet count, and we'll give that for give platelet transfusions for that. Right? For instance, like liver disease, liver makes thrombopoietin. Right? What if the liver doesn't work? Well, now I don't make platelets, so let's give them platelets. Okay, so we got platelets with thrombocytopenia, right? So cytopenia is just penia of cytos. So penia meaning low, right? So you have low cells of the platelet variety, right? Thrombocytopenia. We'll give platelets. If they have a clotting factor deficiency like hemophilia, we'll give them the specific clotting factor. But if they may have a clotting factor deficiency because they're getting an anticoagulant, right? Anticoagulants usually are going to block a lot of things, except for like 10A inhibitors. But either way, PCC is our go-to agent for a anticoagulant overdose. Okay, any questions on the different derivatives? Too many platelets is also a thing as well. Yeah, so we'll talk about that on the platelet slide, about what is too many. Yeah, for sure. Okay, so how to make sure you're getting the right product. So you can't just give blood to anybody. You have to make sure it's the right blood, right? So if it's going to, because like I mentioned, you're going to form antibodies against the blood antigens you don't have. So we gotta assess that. What antibodies do they have, and what antigens do they have? Okay, so we do a type and screen, right? So type and screen is done to make sure there's no transfusion reaction will occur. We take their blood, right? And we identify, like, hey, you have these antibodies and you have these antigens. Okay, how's it different from a type and cross? A type and cross is, I know what you have. Let's take a sample of your blood and let's cross it with the blood product you're about to get, right? And we know we did all the science. We said, oh, this is the blood type you are, and you should not have a transfusion reaction with this blood we're giving you, but we're just going to make sure just in case, right? You're not going to just go based on theory. You're going to say, we're going to take the actual blood and your actual blood, and we're going to mix it and see if it coagulates, right? See if it has a reaction, right? And that reaction is coagulation, right? And why does it coagulate? Well, you have antibodies in your blood, and if they have antigens in their blood that they can attack, that means this wasn't compatible, right? Because you don't want to give antigens to someone that they are going to attack, right? If they do attack, right, that's going to make it sticky, right? So that whole inflammatory process is also a sticky process. So antibodies in the patient's blood will attack the donor's blood, and it will make it sticky, and and that's going to trigger the inflammation, and inflammation triggers a clotting cascade. So now you're getting a clot that's going to start forming, right? And that clot is going to start traveling through the body. It's going to clog the kidneys. So they're going to start getting back pain. It's going to be a and it's going to start clotting a lot of things, and it's cause a huge inflammatory cascade, and it's going to be a really bad situation. Okay, so we just tested in a little petri dish. We're going to go ahead and clot their blood. So in a cross match, we take the donor cells, right? So we take the blood we're going to give them from the bag, right, that was donated. We're going to take that little sample right there. So it looks like this right here, right? So they take a little cut. They just take a little sample off, right? It's like a forbidden honey stick, right? You take this guy off, and then you're going to cut it in half, and you're going to pour it inside the patient's blood, right? And they're going to see if, does it clot? If it doesn't clot, it's compatible. So if you're like Walking Dead, post-apocalyptic, that's one way you can check as well. We can't test you, but does it clot? No? Okay. We're going to give it to you. Hopefully there's no transfusion reaction. Okay? So that is type and cross. But to type a patient, right, we don't want to call the blood bank and tell them, just check all the units, right? See which one works, right? We got to be a little smart about it. We're going to say what the patient's blood type is. And also that empowers the patient as well. If they get in a trauma or something, they say, hey, what blood type are you? And they can say, I'm B positive. And they just call it in the blood bank and get the specific type that they need, right? But there is a type that you can give to everybody. Which type is that? O negative can be given to everybody, right? And we'll give you the reason why that is. Okay, so type and screen, going back to that one. How do you know what type they are? So you want to make sure you take a sample of the patient blood, and we have different antibody solutions, right? They're manufactured, right? Little antibodies, and when you drop the little dropper of this antibody solution in the patient's blood, it may coagulate or it may not. And why would it coagulate? That means the antibody that you're dripping inside the patient's blood is going to have what? Is going to attack that blood because they have that antigen, right? Because antibodies and antigens, when they attack, they start getting clotted, right? They start getting agglutinated. So agglutination or coagulation is what you do not want to happen, right? So again, we take a known RBC type, the patient's serum. So we kind of drip in some little plasma there, and if that antibody in that plasma that you're dripping in there attacks the patient's blood, that means that's not the type they are, right? And you can do some reverse engineering and figure out what blood type they are, right? If I'm giving anti-A, right, antibody against A antigen, I'm giving anti-A, right? So I have giving anti-A to someone, and I'm dripping it into their bloodstream, right? Let's back up here. If I'm giving anti-A to someone, I'll just explain the table next. I'm giving anti-A to someone, that's going to attack A antigen, right? So I can say, oh, you got A blood, right? I'm not going to do that in real life. I'm not going to going to try that out in real life. We're doing it right here in a lab. That way we are in a controlled setting, and we say, I'm giving anti-A. Oh, you got A blood. Well, how do I know you have A blood? Because I gave an antibody that attacked it, right? And then with B blood, right, if I give anti-A, will B blood agglutinate? You give the antibody that attacks A antigen? No, it won't, because B blood is not going to coagulate because it does not have A antigen, right? If I have an A antigen here, I forget what I represented this one as, right? And let's just say that's A antigen, right? And if I give anti-A, it's going to agglutinate. If I give anti-B, which is the antibody for B antigen, it's not going to agglutinate, right? So we give this little plasma of it's like a manufactured plasma that's going to, it might agglutinate, it might not, but we can tell based on the blood type, right? We can figure out the blood type does it clot or not clot, okay? So what else? Patient antigens are what determine your blood type. So if this has A antigen on it, you are type A blood. But how do we know that? Well, we're going to give a little bit of A antibody. We're going to test it in the lab and say, oh, you give A antibody. Well, shoot, it clotted, because that A antibody will attack their antigens and agglutinate. If I drip in some anti-B, it's not going to agglutinate because they don't have B antigens, right? And the last one is the RH factor. I drip in the RH factor, and that will tell me if they have another antigen known as the rhesus antigen, okay? This one does not, right? There's nothing there, okay? If I drop in that antibody against it, it's not going to attack it. But if they did have that last antigen, there's three options. They have either A, B, or rhesus. I like D. It used to be called D. They call it rhesus now. Okay, so that's ABO compatibility. You're assessing if they are compatible with the blood or not. All right, so A antigen, A blood you're going to form antibodies against what you don't have. So in A blood, they're going to form anti-B, right? That's what they're going to do. They're going to form what they don't have. So if you give B blood to someone, B blood has B antigens on it. Yes? Right? You give that to someone with A blood, they are going to agglutinate because they have anti-B in their serum. Okay? Same thing with B blood. B blood means they have B antigens on the blood, and they form antibodies against what they don't have. They're going to have anti-A. So if you give A blood to them, they're going to agglutinate. They're going to coagulate. We're going to test that in the lab first. We're going to say, here's their blood, and I know what's compatible. Let's check it, right? And then we have AB blood. That means you have, remember, the name is based on what antigens they have. That means they have A antigen and they have B antigen. But AB blood has has A antigen and a B antigen. What antibodies do they form? Nothing. They don't form the other antibodies, right? So they can get B blood and they can get A blood. And then our last blood type is O. O for nothing, right? They form no antibodies. So they form no antibodies. There's no, I misspoke. They have no antigens on their blood cell, right? There's no antigens, there's no A or B on it. That means they're going to form antibodies which they don't have, so they're going to form anti-A and anti-B, right? So what blood can you give them? Only O, right? You can only give something else that they won't attack, okay? If you give them A blood, they're going to attack it because they have anti-A in their serum. Okay, and we'll go into more detail on this. So you have antigens that's on the blood itself. Okay, so it can be A positive, B positive, O positive, or A negative, B negative, O negative. Those are your blood type, your antigens that will be on it. And you can double up on a few of these. You can have AB, or that's the other option, right? But those are the only variety of antigens out there. You can either have A, B, and what's the positive one? That's your rhesus factor. So those are the three things that you have to look at. Okay. So you can have type A blood. So you have type A blood. That means what antigens do you have? You have type A blood. You have A's on your cells, right? So type A blood. Let's say I think that's this guy. You have type A here. Okay. So you have A blood there, and then you're going to form antibodies against what you don't have. You're going to form anti-B, right? So so if someone has just the A antigen, they are type A blood. If they have just the B antigen, they're type B blood. AB, they are both, right? They're type AB. They have antigens against A. They have antigens for A and B on their blood. Okay, and we said O blood has no antigens, right? And we can add in, of course, the rhesus factor. So this patient has no rhesus factor, so they are A negative for it. Okay, so A negative blood means they have A antigen and they have no rhesus factor. Okay, if they're A positive blood, that means they have A antigen and they're going to have a little friend on there, right? They're going to have a little rhesus factor on there. That would be type A positive blood. Okay, so A negative blood means they cannot and that's the thing with the rhesus factor is we said you normally form antibodies against what you don't have. With the rhesus factor, you don't always. It's not always formed, and we're not going to take a chance. We're not going to say, oh, it's fine, right? Because if you you may or may not have anti-rhesus, anti-RH. Okay, so you could try, right? You could find out, but we're not going to. Okay, so the rhesus factor is what tells you if it's negative or positive, and sometimes you form the antibodies, sometimes you don't. If you get exposed to it, right, you get exposed to the rhesus factor, that means you're exposed to negative blood or positive blood if you're exposed to it. You're exposed to the rhesus factor, and positive means the antigen was there, right? So you're exposed to positive blood, AB positive, A positive, O positive blood, and you are negative. That means you're definitely going to form antibodies, right? Maybe that first time you didn't have a reaction because you didn't form the antibodies yet. Okay, this happens in pregnancy. So pregnancy is when a mom let's say, B negative, right? They don't have the rhesus factor, but the baby is B positive, right? Or anything positive. They can be another blood type, right? Now they're going to get exposed to it at birth, okay? And that can be a problem. All right, so antibodies. So we represent them as anti-something, anti-this, anti-that, right? Anti-RH factor. And again, the RH factor is the one that sometimes gets produced, but definitely when you get exposed to it. But with anti-A and anti-B, they're always going to get produced if you don't have, for what you don't have, right? So if you are B blood, you form what antibodies? You form antibodies against A, right? If you're O blood, you form what antibodies? A and anti-A and anti-B, because you have no O antigens on you. You have no antigens. You have 0 antigens on you. So you're going to form antibodies against what you don't have, right? If you are O negative, you have absolutely nothing on you. You don't have the rhesus factor, you don't have A, you don't have B. If you're O positive blood, that means what antigens do you have on you? Just the Rh factor, just the rhesus factor. Okay. So you form antibodies against what you don't have, right? And if you were to give someone antigens and they have the antibody against those antigens, you get agglutination. That's a transfusion reaction. That's called an ABO incompatibility reaction, right? And it's usually nowadays a clerical error. Someone made it messed up, right? That's the problem. Okay, so that's the Rh factor, and so this blood right here, this guy is A blood, and he forms, I think B, I put B for blue, right? So he's forming anti-B, right? So these are not B, but anti-B, right? So he has antibodies against B. So can you give this person O positive blood? You could, all right? You're trying to do this whole science experiment. You could give O positive blood to someone, but let's back up. So if you give O positive blood, let's just say if you have positive blood, right, this person could have anti-D. We don't know. This person is A negative. You don't give positive and negatives because you don't want to find out if they have the rhesus factor or not, the rhesus antibody or not, right? But the other question is, when you give O positive blood to someone, why doesn't O positive blood have the antibodies? Doesn't it have anti-A and anti-B in it? So can you give that to someone? Or even like O negative. O negative has no antigens on it, right? And then that means it's in their blood, right? They're forming anti-A, anti-B, anti-Rh. Can you give that to anybody?
If it's just red blood cells.
Good, yeah. So that you have to know the process. You're not giving the whole blood to them. You're giving the packed RBCs. All you're giving is the RBC itself, not the antibodies that are in the plasma. All right. So O negative is the universal donor or recipient? Donor, because it has 0 antigens on it. It doesn't matter who you're giving it to, even if someone has all the antibodies, right? It doesn't matter. They have anti-B, anti-A, anti-Rh, and there's actually like 12 other ones that we're not getting into, but there's all kinds of antibodies that your patient could have. O negative blood is going to work, okay? Because you're not giving the antibodies in O negative blood, you're only giving the antigens that are on the blood cells themselves. Right, so that being said, which blood type forms no antibodies, and they'll accept everything? AB positive or AB negative? So AB positive blood you form antibodies against what you don't have. And AB positive has A, it has B, it has Rh. So what's it forming? Nothing, right? So you give them any kind of blood, they are not going to attack it, because that blood could be A, it could be B, it could be O, right? O has nothing, but if they have B antigen, it comes into their bloodstream, they don't have anti-B, otherwise they would have attacked themselves already. They have A and B antigen, right? So AB positive is universal what? Recipient or donor? Recipient. Universal donor is O negative, okay? So again, this little table right here, so type A blood has A antigens on it, right? And you form antibodies against what you don't have, so you're going to form anti-B. Okay, so can you give B blood to this person? No, because B blood has what? B antigens, and it has anti-A. So you cannot give this to that person, right? To a type A person. Can you give B blood to someone with AB? B blood has what? Has B antigens. If I give whole B blood, that's different. I didn't say that, but because when you give blood, you are giving just the cell, right? You're like, well, if I give antibodies, aren't they going to attack it, right? Isn't that going to happen? Am I giving antibodies or am I giving blood cells? I'm giving blood cells, so I'm giving just the cell itself, right? I'm just giving this guy right here, right? I'm just giving this to my AB friend right there. And my AB friend has no antibodies, right? So it's not going to attack it. right? In the bottom right, there's the same thing, right? So type A blood has antibodies to type B. Type B blood has antibodies to type A, right? And then AB blood has no antibodies. And then we throw in the negative or positive. Do they have the rhesus factor? Do they not?